Thank you very much, Professor Banguti, for being our moderator again today. And we'll just go straight because there's a lot to talk about fluid therapy in the critically ill. All right, Dr. Mashava, good evening, ma'am. You're glad to have you here. So we'll just look at our learning outcome today. Yeah, so we want to understand the importance of fluid therapy in the ICU, in the management of our patient. We want to remind ourselves about the physiology of fluid balance. We want to understand the different types of commonly used IV fluids. We want to also appreciate the indications for fluid therapy in the ICU. And we want to also be able to understand and perform different fluid assessment techniques in our patients. And we should also be able to perform fluid resuscitation protocols and including the different indications for fluid therapy in the ICU. So this is the outline we'll follow this evening. Is a summarized outline, and as we go on, we'll see more into what we're doing. So by way of introduction, fluid therapy is a critical aspect of care of the critically in the ICU. Very important. A lot of times we often neglect it, but proper fluid administration can and will significantly influence our patient's outcome, especially in the ICU. All right, and we remember antibiotic stewardship. There's a concept known as fluid therapy stewardship, which is very crucial in achieving good outcomes and to prevent complications associated with fluid therapy. So we're going to look at it as we go on in the course of this tutorial. All right, so like I said, let's remind ourselves of fluid compartment. All right, remember the 60-40-20 rule. All right, the first one is the total body water accounts for approximately 60% of the body weight in males and 50 to 55% in females. And remember that total body water is made up of the intracellular fluid compartment and the fluid in the extracellular fluid compartment. So the 40 rule there is that the intracellular fluid makes up the 40% of the total body water. All right, that's about 2/3 of the total body water of our patient. And this intracellular fluid contains ions like potassium, magnesium, phosphate, and proteins. These are the major ions that are contained in the intracellular fluid compartment. The extracellular fluid constitutes 20%. That's about 1/3 of the total body water. All right, and it's also divided into a major compartment, the interstitial fluid and the plasma. The major ions in this compartment is sodium, chloride, and bicarbonate. And you will see on the right side of the slide, you will see how this is further divided on in the 70 kg man. All right, we'll look at the body weight and all that. So this is just a reminder as we go on. Fluid is usually tightly controlled, and that's why we're talking about fluid homeostasis. So how is fluid usually controlled in the body? And we have two systems that are involved in regulating fluid homeostasis. The number one is the role of the kidneys. The kidneys are very important, are very essential in regulating fluid volume and composition. And they do this by filtration, all right, the reabsorption and secretion of fluid and electrolyte. The second system is hormonal regulation of the AAA, all right, the antidiuretic hormone, also known as vasopressin, and the aldosterone. Just to remind us of physiology, remember that the antidiuretic hormone is produced in the hypothalamus, but it's released from the posterior pituitary gland. And is released, all right, is in, if you look at the slides on the right side, when there's high body water content, all right, you have less ADH that is released, leading to less absorption of water and the patient will have more urine. All right, but when the body water content is low, you have to conserve water, and that is where there will be increased ADH release, where more water is absorbed into the body to conserve water homeostasis, and you have less urine being produced. Aldosterone is a hormone that is produced in the adrenal cortex, all right, promotes sodium reabsorption and potassium excretion in the kidney, and indirectly increase water retention. The third one is the atrial natriuretic peptide that is released in the right atrium that usually is respond to seasons of hypertension, and all these help in regulating fluid homeostasis in health. All right, I'm sure we remember Frank-Starling's, the Frank-Starling forces, all right, that determine fluid movement among the different compartments, especially in the capillaries, all right, where we have to talk about the oncotic and the hydrostatic pressure. So movement between the capillaries, all right, is determined by the net force between the oncotic and the hydrostatic pressure. But here we're going to be talking about the impact, the Frank-Starling mechanism on the heart, all right? And because the essence of our fluid therapy is to increase cardiac output and maintain mean arterial pressure. So Frank-Starling mechanism is a physiological principle that helps to explain how the heart responds to changes in venous return. All right, in a normal heart, increases in venous return will cause the heart chambers to fill with more blood, and what will happen is that it causes the myocardium to stretch and contract more forcefully, and leading to increased cardiac output. The reason why this is important physiologically is that increase in the venous return, increased return of blood volume into the heart will distend and make the heart overloaded with fluid. But this mechanism teaches how the myocardium responds to increase in venous return by increasing contractility. Now, if you look at the diagram on the right side, you'll see the blue line. All right, this is very important. You see the preload, that is your end diastolic volume, all right, and this is your stroke volume. So as your preload, which is your end diastolic volume, increases, contractility of the myocardium increases, which leads to an increase in stroke volume. All right, but it gets to a point, this flat portion of the graph where there's little or no volume effect following bolus. So at this point, there's what we call fluid unresponsiveness. All right, so myocardial contractility is independent of your preload. Now, in a failed heart where we have reduced contractility, the increase in stroke volume is also reduced, all right, with increase in preload or your end diastolic volume. So this is very important. The greatest effect in stroke volume or cardiac output augmentation occurs at this level of the graph where you have a steep increase with an increase in end diastolic volume. All right. So like I mentioned, reduced fluid responsiveness may occur either due to reduced contractility, this red line, this curve below here, or the plateau, all right, just like your oxygen dissociation curve, all right, this plateau has reduced fluid responsiveness according to Frank-Starling mechanism. All right, it's crucial for us to remind ourselves how to assess fluid balance in our patients in ICU, and there are different ways to do that. You can do physical examination, assessment of skin turgor, mucous membrane, jugular venous pressure, edema, and if you have invasive line, you can do arterial waveform and your central venous pressure waveform. Vital signs, all right, monitoring the blood pressure, heart rate, respiratory rate is important. Even temperature can help to assess fluid balance in your patient. Laboratory tests, your serum electrolyte, especially your sodium and potassium, could help gauge fluid balance in your patient. Blood urea, nitrogen, creatinine, hematocrit, these are tests for renal function that can help decipher the balance of your fluid in your system. All other imaging and monitoring, especially ultrasound with your IVC diameter, we're going to be looking at it very shortly. Now, this is important that we perform what we call passive leg raise, all right? And this is, this try to mimic the effect of fluid loading without actually administering your fluid. And we do this regularly in our ICU. So what happens is that the patient lying supine on the bed. Remember that most of our patients are usually head up 30 to 45 degree. But when you want to perform passive leg raise, the patient must be returned supine and both legs are raised to about 45 degree, and you keep these legs straight and maintain this position for 1 to 3 minutes. While you are doing that, you want to monitor your hemodynamic parameters like your blood pressure, heart rate, and if you have an invasive arterial line, you can also see the changes in the arterial waveform. It's important for us to know how to interpret this. A positive response, that is an increase in your cardiac output or stroke volume, which will be reflected in an increase in your blood pressure or mean arterial pressure during passive leg raise, suggests that this patient is fluid depleted and is likely going to benefit from fluid administration. However, a lack of improvement in your hemodynamic parameters is an indication that additional fluid administration may not be beneficial or could lead to fluid overload in your patient. As important and useful as passive leg raise is, it has some limitations, especially in patients with cardiac arrhythmias, patients with intra-abdominal hypertension, that limits the effect of your leg raise on venous return. And sometimes your patient will have severe heart dysfunction, and that we talked about the reduced contractility of the myocardium when we looked at Frank-Starling mechanism. All right, another way to assess fluid responsiveness or fluid status for your patient is the pulse pressure variation. All right, what it does is that it measures the variation in your pulse pressure during respiratory cycle. Let's remind ourselves that pulse pressure, refers to the change between systolic blood pressure and your diastolic blood pressure. All right, during positive pressure ventilation, especially for patients who are mechanically ventilated, or even if you're doing ambu-bagging, all right, increase in venous return. There's an increase in venous return during inspiration, and this decreases during expiration. So now when you have increase in venous return, you expect an increase, all right, in your systolic blood pressure, and you have a greater margin of your pulse pressure. So the cyclic change in venous return will affect left ventricular stroke volume differently depending on the patient's preload status. So how do we interpret that? All right, a pulse pressure ventilation is calculated as the positive pressure, the maximum positive pressure minus the minimum positive pressure divided by the average of the two, and you multiply it by 100%. So if it's greater than 15%, if your pulse pressure variation is greater than 15%, it's suggestive that your patient is likely going to be fluid responsive. So a fluid bolus will likely increase stroke volume, cardiac output, and your mean arterial pressure. However, a pulse pressure that is less than 50, a pulse pressure variation that is less than 15% indicates that your patient is not likely going to benefit from additional fluid administration. All right, many of us that have ultrasound in our unit, we do this regularly. All right, I try to make my doctors to combine passive leg raise and IVC diameter and collapsibility index measurement, because it makes you safer, especially when you are deciding whether to start vasopressor or your patient requires additional fluid bolus. All right, so let me just show you the next slide. All right, on the left side is an ultrasound image of your IVC. And don't forget that there are two luminal structures intra-abdominally, the aorta and your inferior vena cava. All right, but how to note to identify your IVC is that it's very closely related to the liver, and you want to look for the hepatic vein that empties into the inferior vena cava. And also, you can also see how the inferior vena cava empties into the right atrium. All right, and this is how to locate your IVC if you're using subcostal window with your curvilinear probe. Now you measure this quarter to, I'm trying to move my, yes, I don't know if you can see my arrow. You measure your IVC distal to the entrance of the hepatic vein, and you measure it. That is the IVC diameter. And you can also measure collapsibility index, all right, the degree to which the IVC collapse with expiration. And this is very crucial, especially in the ICU. All right, sometimes you may not want to do passive leg raise because turning the patient supine, especially for ventilated patient, you may have issues with regurgitation and aspiration of your gastric contents. All right, but IVC diameter measurement and the collapsibility index is very handy and something you can do within 5 minutes, and you can decide. One good thing about measurement of IVC diameter and collapsibility index is that you can compute and correlate it with your central venous pressure. So if your IVC diameter is less than 1.5 centimeter with 100% collapsibility, it shows that your CVP is between 0 to 5 centimeters of water or millimeter of mercury. IVC diameter between 1.5 to 2.5 with more than 50% collapsibility is an indication that your CVP is between 6 to 10. All right, if there's less than 50% collapsibility, your CVP is about 11 to 15. And when you have IVC diameter greater than 2.5 with less than 50% collapsibility index, your CVP is definitely high. And when you have no collapsibility at all, your CVP is definitely above 20. And how do you interpret this? When you have very low IVC diameter with high collapsibility index, it shows that your patient is fluid depleted and this patient will benefit from fluid boluses. And it has really helped a lot of times. And one other thing about the use of ultrasound in this group of patients is that you can actually look at you can do a long ultrasound to assess for B lines to check whether your patient is fluid overloaded. So in one breath, you can do your subcostal window access of the IVC, and you can actually also check for you're doing your long ultrasound to assess for B lines to rule out fluid overload. All right, another very important ways to measure fluid assessment is the National Early Warning Score. All right, the one I put on the right is actually from the Royal College of Physicians, and this is important because you can use it to determine when your patient requires fluid or not. All right, these are the various parameters that are monitored: the respiratory rate, your saturation, systolic blood pressure, pulse rate, the level of consciousness, or there's a development of new onset of confusion, and your temperature. It's been said that when your new score is greater than 5, there's potential presence of hypovolemia, and this patient most likely may benefit from fluid administration. But note that this is not, one jacket fit all. You need to put in mind the different clinical scenario before you proceed to replace fluid in your patient. All right, so there are 5 hours of intravenous fluid administration. All right, we want to talk about resuscitation, routine maintenance, replacement, redistribution, and reassessment. So that these are the different indications for fluid administration, and we're going to dwell more as we go on in the course of the tutorial. Now, I mentioned fluid stewardship. Actually, let me say here that henceforth we should treat fluid administration of fluid as a drug. All right, fluid is not innocuous. Fluid is not without its demerit. So, as we need to treat fluid therapy as your vasopressor, as your antibiotics, and in doing that, you need to ensure that you have the four rights in fluid management. All right. Like I said, one fluid does not, take care of all patients' conditions. So the number one thing, you want to ensure that you are giving your patient the right kind of fluid. All right. You want to also give fluid for the right duration. All right. You want to give your fluid at the right dose. All right. And you want to give your fluid to the right patient. All right. Except the fluid requirement for a septic patient is different, definitely, from a patient with acute kidney injury. It's different from patient in burns, different from patient in congestive cardiac failure. So fluid should be treated and regarded as a medication in the ICU. All right, just to remind us, there are different two types of fluids generally, crystalloids and colloids. All right, and the common crystalloids we use in the ICU include your normal saline, though it has been questioned. There is nothing normal about normal saline. All right, those days we used to say normal saline because it constitutes the ions almost equal to that of plasma, but know that the pH is more acidic. All right, so it has sodium concentration of 154, and it's important, especially when we are calculating sodium deficit and how to replace your sodium deficit. So you need to know the sodium content of your normal saline is about 154. All right, the osmolarity about 308 milliosmol per liter. All right, pH about 5.5, so it's slightly more acidic than plasma. All right, uses of normal saline, maybe I should call it 0.9% saline, because like I said, there's nothing normal about normal saline. All right, use of 0.9% saline includes volume resuscitation. All right, a lot of times you want to use it for in patients with metabolic alkalosis, and also for replacement of sodium deficit in hyponatremic patients. But realize, please note that in replacing sodium in hyponatremic patient, you need to consider the volume. All right, we usually prefer hypertonic saline because the volume of replacement is smaller compared to that of 0.9% saline. All right, it's very available, not expensive, and it has low risk of allergic reactions. But don't forget that it can cause hyperchloremic metabolic acidosis, all right, because it aids, all right, excretion of bicarbonate at the distal cumulated tubules, so it can cause hypochloremic metabolic acidosis. And in replacing hyponatremia, it can actually lead to fluid overload, and that's why we prefer hypertonic saline in these patients. All right. Thank you. I see somebody. Please kindly switch off your video. All right. Please, let's just make the experience worthwhile for everybody. Please comply. All right. So the second fluid we're going to look at is the Ringer's lactate. Sometimes we call it Hartmann's solution, but there's a slight difference, all right, between the two in terms of their composition. All right, Ringer's lactate, the advantage it has that it has two other additions, calcium and lactate. All right, this lactate can be metabolized to bicarbonate, and that's why it is useful, all right, in treating metabolic acidosis. So sodium content of Ringer's lactate is about 130, chloride 109, potassium 4, calcium, all right, is added here, and the reason why calcium is added here, it reduces all right, the concentration or the content of sodium in order to maintain neutrality in the fluid. So the sodium content is far lower than your 0.9%. And this also causes problems because, the American Society of Hematology and Blood Transfusion clearly states that Ringer's lactate is contraindicated in diluting blood because of the calcium chelation, the chelation property of calcium that it has. All right, it has the pH is closer to plasma. All right, and is a useful fluid for fluid resuscitation in burns patients and for patients with acute blood loss. All right, and it can also be used to treat metabolic acidosis because of the presence of lactate, which is metabolized by carbonate. However, like I mentioned before, it's not suitable, all right, for diluting blood products because of the presence of calcium, and also the potassium may also be problematic because it can actually cause hyperkalemia if it's used in large volumes. Plasma light, all right. If you look at it broadly, crystalloids can actually be divided into balanced source solution and unbalanced source solution. So 0.9% saline, Ringer's lactate, or your Hartmann solution belong to the unbalanced source solution group. Plasma light or normal soil depends on where you're practicing. All right, plasma light and normal soil are more balanced source solution because they are the closest to plasma. All right, sodium 140, chloride 98, potassium 5. It has magnesium added to it, acetate, which is metabolized to bicarbonate, gluconate, and all that. So plasma light is a better balanced source solution. And it's important a lot of times when you are in the ICU. Remember, in the previous unit I worked, all right, we had to be making use of plasma light because it was available, and it helped most of our patients compared to Ringers and your 0.9% saline. 5% dextrose in water is not a common fluid that we use. Its indication is actually for free water to correct hypernatremia, all right, and it's also useful as a carrier for many of your medications. So because it has no electrolyte, it's suitable for delivering water. But note that in our patients where we insist or we desire tight glycemic control, be careful of 5% dextrose water because it can cause hyperglycemia. And know that it's an ineffective drugs for volume resuscitation. Yeah, hypertonic saline. All right, hypertonic saline, 3% sodium chloride, that is about 30 grams, all right, 100 ml of the solution. The sodium content is about 513, all right, pH of 5.0, all right. It's useful majorly for two conditions: treating severe hyponatremia, all right. It is a low volume resuscitation fluid or replacement fluid for hyponatremia, and is also used as an osmotic diuretics, especially in reducing your intracranial pressure. It's effective in rapidly increasing serum sodium levels, but you need to monitor it, and the rate of correction you need to be cautious because rapid correction can lead to osmotic demyelination syndrome. All right, and also it must be infused through a central line because it can cause venous irritation of the peripheral vein. All right, so this is a table. I'll leave this with you so that these are some of the things I've mentioned before. All right, this is just to drive on the point. All right, the second type of fluid that we use in the ICU are colloids. All right, and we have different types of colloids. The albumin can come in either 5% or 25% concentration. This albumin is really made from serum albumin, which is preheated. And it's actually very important, especially in hypoalbuminemia, which is common in many of our patients. Patients in sepsis, burns, liver cirrhosis will benefit from albumin, infusion. All right. It has a long-lasting volume expansion, as we're going to see later on as we go on, because it stays more in the intravascular compartment, so it gives you a better cardiac output augmentation, and it has a lower risk of edema compared to crystalloids. But one of the problems, especially with all colloids, is that they are expensive. They can lead to coagulopathy. All right. At those days when we were in training, we were taught by our mentors that you do not give albumin until you have collected your blood sample for coagulation studies, because your colloids can interfere with coagulation study, because it can cause coagulopathy. And the risk of allergic reaction is always there with all colloids without exemption of albumin. All right, hydroxyethyl starch, all right, is used for volume expansion, has almost the same composition, like 0.9%, and the osmolality varies with the different preparation. So the pH ranges between 5.5 to 7. Basically used for volume resuscitation. Like I told you, it's associated with coagulopathy and allergic reactions, and because of all this, and because it can also induce renal dysfunction. All right, its use has usually declined in recent time. Gelatins and all that are also parts of your colloids. Okay, and I like asking this question from my medical students: what are the differences between crystalloids and colloids? And it's important for us to just remind ourselves when you get the slide or when you listen to the video. All right, so the first thing I mentioned is resuscitation. I think I should do a little more on resuscitation as we go on. Hopefully, we'll come back to this. All right, the rate of volume infusion in hypovolemic shock is crucial because it has a significant impact on patient outcome. Studies have shown that the longer your patient is in hypovolemic state, and the magnitude of the hypovolemic shock can impact greatly on outcome. So the earlier the hypovolemic shock is corrected with appropriate volume and at rate, is very important. So now, but know that this is dependent, the rate of volume infusion or resuscitation in hypovolemic shock is dependent on two factors: the size of the catheter you're using and the type of fluid that you're using for resuscitation. All right, if you remember the Hagen-Postellin equation, where you have change in pressure, all right, flow is equal to change in pressure pi radius raised to power 4 divided by 8, all right, and the viscosity of the fluid and the length. All right, so the flow, all right, the flow, which is Q is equal to change in pressure pi radius raised to power 4 divided by 8 multiplied by the viscosity of the fluid and the length of the catheter. So for rapid volume infusion, all right, it's important that we cannulate the peripheral veins that require short catheters, at most 2 inches. All right, cannulating the central vein. The central vein is bigger, but it's not the size of the vein that matters. It is the length of the catheter, which is about 6 to 8 inches. All right, so for rapid volume infusion, it's better you cannulate the peripheral veins that will require short catheters. And also remember that the flow of fluid across tubes of vessels is also increases with the fault of the radius. So rapid volume infusion is preferred with using large bore catheters, all right, like introducer catheters. So if you have a patient in here hypovolemic shock whether hemorrhagic or whether GIT losses. Remember, for you to achieve rapid volume infusion, you want to use your peripheral vein with a large bore catheters. The second, the factor that determine the rate and volume of infusion when you need rapid fluid resuscitation is the type of fluid that you are using. If you look at that, the formula, note that the flow, the rate of flow is inversely proportional to your viscosity of the fluid. So fluids that contain cells like your whole blood or your packed red cells, their flow will be limited compared to crystalloids that have no cells. So for instance, whole blood flows less rapidly than cell-free fluids like crystalloids or packed red cell. All right, actually, packed red cell has the least flow rate. All right, and what we do, especially when we need to correct anemia, in hemorrhagic shock, is to increase the driving pressure by the inflatable cup wrapped around the blood bag. All right, you can also add equal volume of isotonic saline to reduce the viscosity of your packed red cell. Now note that albumin solution is actually ideal, all right, for volume resuscitation in hypovolemic shock, because number one, it has no cell and it has a viscosity that is comparable to water. Now, what is the end goal of fluid resuscitation, especially in hypovolemic shock? All right, the end goal is the augmentation of cardiac output. All right, and it's been found that colloids is the most effective resuscitation fluid to augment cardiac output. All right, on a volume to volume basis, colloids are twice as effective as whole blood, 6 times more effective than packed red cells, and 8 times more effective than crystalloids. All right, so if what we're doing, if our end goal is to augment cardiac output, colloids are our best bet. Why? Because they are restricted to plasma, all right, because of the large molecules they contain, and they do not readily move out of the TCR fluid, so they can contribute to your venous return and increase your cardiac output. All right, so crystalloids will require 3 times the volume of colloids in order to exert similar effect in augmenting cardiac output. Now, it's important for you to calculate, like I told you, fluid should be taken as a drug in order for you to calculate the volume of resuscitation. All right, for in hypovolemic shock, there are 2 steps you want to take. Number one, you want to estimate, all right, the volume of blood loss, all right, like we do class 1 to class 4. And after you have done that, the volume of resuscitation can be calculated by the volume loss. All right, for instance, a patient that has lost about 15 mils per kg, so 15 mils times 70 will become the volume loss, and you divide this by the plasma retention ratio of the fluid you want to use to resuscitate such patient. Remember that the plasma retention ratio of colloid is 0.75. What it means is that 75% of your infused colloids will stay within the intravascular compartment, while crystalloids, only 25% will stay in the intravascular compartment. So this is how to calculate the volume that is required in resuscitating your patient in hypovolemic shock. Now, you want to have endpoint. What do you want to achieve? There are 2 endpoints that we can use. The traditional endpoint, all right, is the normalization of blood pressure and urine output. But it's been found out that even after normalization of blood pressure and urine output, more than 85% of our patients will continue to show evidence of tissue hypoperfusion. So the fact that blood pressure is normalized and urine output is now more than 0.5 ml per kg per hour, you want to go to sleep that you have resuscitated a patient. No, about 85% of those patients having normalized blood pressure and urine output will continue to have evidence of tissue hypoperfusion. So that brings us to the second way to assess endpoint of fluid resuscitation. And there are three of them. You do oxygen uptake. All right, your oxygen uptake should be more than 100 mil per minute per square meter. All right, and this is can be useful. Then one way to do is that you can do your SVO2. That is the venous oxygen saturation. If your venous oxygen saturation is more than 75%, it shows that your oxygen uptake, all right, is optimal. Then arterial base deficit should be greater than 2 millimole, and your serum lactate should be less than 2 millimole. All right. Now, in hypovolemic shock from any point, whether hemorrhagic or vomiting and diarrhea or any form, the goal is to achieve your endpoint within 24 hours of onset of hypovolemic shock. A lot of times this may not be achievable, but that's what we should aim at, that you should have arterial base deficit greater than 2 millimole. Your serum lactate should be less than 2 millimole per liter within 24 hours of the onset of hypovolemic shock. All right, so that is resuscitation. The other one is when we talk about the maintenance fluid, which is important, especially for patients who are on NEPA or patients who cannot, tolerate fluid orally. All right, maintenance actually addresses the physiological needs of the fluid physiological needs of the patient, which includes sensible and insensible fluid losses. Let's remind ourselves that the daily requirement, daily needs for water is about 25 to 30 mil per kg per day. All right, and this is what we normally calculate, that we give our patient empirically 100 mil per hour. All right, if you calculate that, you get up to about 30 to 40 mils per kg per day for an averagely weight patient. Your sodium requirement is about 1 to 2 milliequivalent per kg or millimole per kg per day, and your potassium should be around 0.5 to 1 millimole per kg per day. And you need at least 100 to 150 grams of glucose per day to prevent ketosis and the use of protein, breaking down protein to make energy requirement. So when your patient has been fluid resuscitated, you want to ensure that you have adequate fluid maintenance to ensure that their daily requirements are met. Now we call the replacement fluid. Sometimes we have ongoing losses from various pathological conditions, all right, vomiting, diarrhea, and thought space losses. All right, from the GIT, you can have fluid losses from vomiting, diarrhea, and don't forget NG2 functioning. NG2 functioning is a source of fluid loss. And I don't know how many of us calculate our NG2 functioning and incorporate it into the losses that the patients have. So what you need to do is you want to replace fluid. The type of fluid is important. It's different, for vomiting and diarrhea. And if we have time, we'll come across it as we go on. All right. The other one are the renal losses. Okay, and I have a slide. I hope we'll be able to touch on that. Polyuria due to your diabetes insipidus, or sometimes diuretic use. I like using low dose infusion, continuous infusions of furosemide for my patient, or especially because it helps keeping the patient dry for your ventilated patient. And also furosemide has been known as an antioxidant. So for patients that require close monitoring, I usually give them 0.1 to 0.5 milligram per kg, all right, per hour for furosemide. But in doing that, you have your patient becoming polyuric, and you want to replace the lost fluid to maintain intravascular volume and electrolyte balance. All right, the other one is what we call thought spacing. All right, remember that we talked about the fluid compartment, the intracellular and the extracellular fluid. All right, but sometimes your fluid that you infuse or fluid in the body can go into the interstitial space or other body cavities like your peritoneum, your bowel lumen, even in the pleural space. Now you have fluid there. This is a case of having fluid yet hypovolemic because the fluid has gone into the third space, and you need to account for this, especially in trying to maintain fluid homeostasis. Common causes of third space loss includes what I call stop. So the idea is to stop third space loss. All right, this includes sepsis. All right, surgery trauma. When you have intestinal or venous obstruction, patients with acute pancreatitis, or when you have low plasma proteins to defend the oncotic pressure, or you have permeability of your capillaries. Those are the common causes of third space loss. And what you need to do is you want to be aggressive, all right, because the patient may look edematous, may look fluid overloaded, but yet the effective intravascular fluid volume is low. Yeah, somebody mentioned, glycocalyx. Yes, thank you. Starch-containing fluids are very detrimental. Yes, we may talk about glycocalyx theory, but not especially on this discussion. Thank you for that, Solomon Y. Hopefully, at the end of discussion, at the end of the tutorial, we may have a discussion on that later on. Thank you. Dubia talked about albumin administration and mortality in the ICU. We're going to talk about that. Please, I like this discussion. We're going to have the discussion as we come to the end of the tutorial. All right. Okay, how to calculate fluid administration. We talked about this. I'm sure we're familiar with that. All right, and okay, so we want to just briefly talk about. Let me look at the time. We want to briefly talk about. Oh my God, I have 9 minutes more. All right, before the hour, and I want us to have that discussion. So disorders of water imbalance, water balance. All right, we have two major considerations. Yeah, diabetes insipidus and central. We have two of them. We have the neurogenic DI and the nephrogenic DI. It's important for us to be able to identify this. And the neurogenic DI is actually due to deficiency of antidiuretic hormone production, or there's deficiency in release from the hypothalamus or pituitary gland. All right, and this will show by low serum ADH levels. If you do a water deprivation, you'll still find out that the patient is unable to concentrate urine despite the dehydration. And when you give your desmopressin, all right, your synthetic vasopressin, you will see an improvement, all right, and you just be able to make the diagnosis. Nephrogenic DI, all right, this is due to the kidney's inability. There's normal ADH, but the kidney is unable to respond. All right, you see normal to high serum levels of ADH. There's persistent inability to concentrate urine with your water deprivation test. And even when you add desmopressin, there's no response. All right, because of time, we have the syndrome of inappropriate ADH secretion. All right, and this is characterized by excessive release of ADH. All right, this leads to increased water retention, dilutional hyponatremia, and you have reduced serum osmolality. These are some of the causes. Time is going, and all right, you treat that, you do all that. So fluid resuscitation protocols. All right, like I mentioned before, the primary role of fluid resuscitation is to maintain organ perfusion. All right, and you want to increase substrate delivery through the administration of your fluid. So the general principle is to first of all evaluate patient's hemodynamic status, all right, via the clinical or the passive leg raise or IVC diameter measurement. All right, initial fluid choice. Yeah, this is what we're coming about, Solomon. We will talk about it here. All right, so the initial fluid choice, we want to start with the isotonic crystalloids. All right, I would prefer the balanced salt solution plasma light, or what we call isolite or normoso. all right, unless there's a specific indication for an alternative fluid, especially in sepsis and burns where albumin comes very handy, all right, especially in the initial phase of resuscitation. Albumin, although has effect on the glycocalyx, which we may discuss. I would like to have a robust discussion on that. But in terms of initial resuscitation, albumin still has a role to play, especially in burns and in severe sepsis. All right, you want to decide volume and rate administration. All right, typically you want to give 1 to 2 liters in adults or 20 ml per kg. But be conscious as you do this, and that's why ultrasound is very important in the ICU. You want to continuously monitor your vital signs, and you want to use your dynamic assessment methods like we mentioned before, the passive leg raise, the pulse pressure variation where available, and you want to adjust the type and rate of fluid based on ongoing losses, all right, GIT losses, renal losses, or even thought spacing. All right, so specific protocols. Let me look at the time again. Specific protocols, 5 minutes. Septic shock requires prompt and aggressive fluid resuscitation, all right, to improve tissue perfusion and organ function. So the first choice is actually isotonic crystalloids, but I mentioned before, all right, gas lighted or normal saline is preferred, but in some severe sepsis, all right, with reduced albumin level, albumin can actually, I've seen that clinically come handy. All right, so during fluid bolus, you want to assess your patient every 15 to 30 minutes, and you want to use your dynamic measures to ensure fluid responsiveness. This is important because with your IVC or your passive leg raise, it is easier for you, or is faster for you to determine when you're going to initiate vasopressors. Like I tell people, you don't initiate vasopressors until you have adequately fluid resuscitated your patient, because when you give your vasopressors to a fluid deplete patient, you're just pumping an empty tank and it won't work. In fact, it really have more deleterious effect in your patient. All right, consider colloids. If large volume of crystalloids are required, this is another place where the use of colloids, especially albumin, comes handy. In hypovolemic shock, we mentioned this before, but just for the protocol, all right, if hypovolemic shock is due to hemorrhage or severe dehydration, you require rapid volume replacement. And like I mentioned before, the size of your catheter in terms of the length and the radius is important. You want to administer 1 to 2 liters, all right, and assess hemodynamic response. Sometimes if it's due to hemorrhage, obviously you want to administer your Pacres cells to correct hemorrhage. In cases of massive blood transfusion, you want to do massive transfusion protocol with a 1-to-1 ratio of Pac cell, plasma, and platelets. All right. So ongoing monitor for signs of fluid overload, electrolyte imbalance, and the incidence or occurrence of coagulopathy. All right. Okay, I like this. So, Solomon, I like that. There's a school of thought backed by studies showing that early use of a suppressor gives better outcome than considering after fluid responsiveness. We'll discuss that at the end of this tutorial. I like this engagement. It's good for us to discuss that. We don't have time to go over this algorithm, but it's important for us to just check it up as we go on. All right, cardiogenic shock because of time, burns patient. All right, you want to use your Parkland formula, okay, and we all know this, so that we just. So there's this other discussion on Libre or restrictive fluid therapy. All right, people have advocated for different school of thoughts, and the debate still actually rages on. All right, some people believe in Libre fluid therapy. all right, because of the benefits like rapid correction of hypotension and improvement of tissue perfusion. Like I mentioned before, the earlier hypovolemia is corrected, the better the outcome for the patient. And also, it prevents acute kidney injury that is associated with hypovolemia, your pre-renal causes of your AKI, and also helps in increased or enhanced delivery of oxygen and nutrients to your tissues. The problems include fluid overload. All right, there's increased risk of pulmonary edema, which will worsen your oxygenation and prolong mechanical ventilation, acute respiratory distress syndrome, and delayed recognition of tissue perfusion because your liver fluid can mask inadequate tissue perfusion, because giving fluid alone does not ensure adequate fluid resolution of your tissue perfusion. And that's why we talked about the systemic endpoints, your oxygen uptake and your arterial base deficit and all of that. All right, restrictive. I belong to the school of total restrictive fluid therapy, all right, because it has reduced complications associated with fluid overload and all that. It also preserves, I always like to keep them dry, especially for my ventilator patients. So restrictive fluid therapy. But the critics of restrictive fluid therapy talks about delayed fluid resuscitation, all right, delayed renal perfusion. But the idea is to have individualization of our patients to ensure that the right fluid, like we talked about fluid stewardship, the right fluid at the right dose at the right duration is given to the right patient. All right, so evidence-based, I quoted some studies here for our benefit. All right, so okay, Schneider and colleagues, published this research in 2016. I think it's good for us to look it up, where they said hypovolemia should be diagnosed like any other disease. All right, you need to diagnose it by going through the systemic way of diagnosing any kind of disease, by history taking, physical examination, volume responsiveness, like we mentioned before, other indicators like your dynamic measurement. But you said that you want to avoid the use of pulmonary artery occlusion pressure because of the invasiveness of a certain pulmonary artery catheter. All right, they are of the opinion that balanced crystalloid, your plasmalide, your normal soil, isolide, should be used as first line. And I'm sure that there's been some also controversies, concerning this. All right, people have talked about Ringer's latte and all that, but it's important that we just have our discussion based on randomized control trials. Colloids are beneficial in restoring blood volume rapidly, especially like I mentioned before, when it has to do with restoring, when the ultimate goal is to augment cardiac output as soon as possible. But avoid hypertonic start solution, all right? It's hypertonic start solutions that we should be worried about. Thank you very much. There are so many other things here. Just run, there are consequences of fluid mismanagement, all right? And some organizations and body have said that the consequences of fluid management should be a reported critical incident in the ICU. So when you have hypovolemia or when you have pulmonary edema from fluid overload or hypo or hypernatremia, these are reportable critical incidents in the ICU. These are some of my references. Thank you very much. Professor Pauline, you may take it off from here.
Thank you very much, Professor Toby Kingsley.